So this chapter 39 from your para and peri is the exemplar for the concept of mobility. So immobility, as I said in the previous PowerPoint. Um, so for in order to be able to really prevent problems and implications of impaired mobility, you need to, like we stated before, go back into your EMP and really refresh your knowledge about the skeletal system, the muscles, the nervous system, and I want you to, in addition to reading and focusing on chapter 39 and Parampere, to go to chapter 38. It's the chapter about activity and exercise. And I know in the lab you're going to be doing these activities where you're going to practice body mechanics and practice positioning your patient, bathing your patient. So the base scientific knowledge is going to be important in order for you to help your patient rather than you being part of the problem. So you're going to have to um, if you're assigned to a patient that has an impaired mobility, your role is to enable them to get to their optimum uh, functional level and not be part of the problem where we may create a pressure injury for the patient or um, contractures because we're not doing those range of motion exercises. Reading into that chapter, chapter 38, it tells you that the nursing knowledge base is you bringing forward to uh, this exemplar of immobility. You need to know safe patient handling and mobility. What factors affect activity and exercises, from age factors to behavior factors to cultural factors, environmental issues are going to be also part in there. Then um, does the family or support system help in achieving our goal when we are thinking about mobility? Then, as a nurse, also whether you're assessing a normal functioning body or you're picking up to see if there's abnormalities, you need to go through the nursing process, and um, that is very essential because I need to know how is adequate exercise affects the cardiovascular system. How does it affect the musculoskeletal system? How does it affect the respiratory system? Um, Before I jump in and say, okay, this is how I'm gonna do what I'm gonna do to help the patient uh, that has immobility problem. Do I know what are elements that contribute to activity tolerance versus what contribute to activity intolerance? So please go back to chapter 38. You're gonna need to read it anyways for your lab upcoming two lab sessions, and so um, it's not an additional reading material for that matter. It is just you tapping into resources that are at your fingertips. So to recap, we remember that our musculoskeletal system and nervous system work in coordination to maintain the balance, the posture, the body alignment during all our activities of daily living. And being active is very essential for promoting and maintaining health and keeping the function of our body system at optimum level. And we have a role when our patient becomes immobile, whether it's because of a illness, surgery. We have a role in preventing complications. Deep vein thrombosis is one of the complications of being immobile on the um, blood level. And then, as nurses, are we using the proper lifting devices? Do we know those proper lifting devices? And can we assess the patient? Do we know how to ask the questions to pick up whether the patient has a weakness, whether they have inability to ambulate, or are they able to perform their activities of daily living. What vital signs are indicative that the patient has activity intolerance. So all these are going to be knowledge, scientific knowledge base you're bringing forward. And then when we look at immobility, now we're looking at what could go wrong, what is the pathophysiological processes happening when the person is immobile. So we're going to look at each system on its own, but know that, a patient that comes with a joint problem, your patient that has a knee problem, or a patient who just came for a hip replacement, it's going to be impacting that nature of movement. We need the joints to be functioning well so that we can move that limb. So that's where you bring forward your knowledge base into your nursing role and your nursing process. When we think of the effects of immobility, we have to recognize that physiologically, every system in the body is going to be affected by immobility. There is no system that's immune, but that effect is going to be dependent on the client's health, what do they come to the table with, their age, their degree of immobility, of mobility or immobility. All these are going to play a factor in. So let's look at each system individually. When we talk about metabolic changes, for example, what might cause in metabolic system, for example, when we have a patient that has decreased mobility, they're going to have decreased metabolic rate, and that is going to change how we metabolize the food chain, the carbohydrates, the fats, the protein. It's going to affect the fluid and electrolyte imbalances, and we're going to see, calcium changes, and we know that calcium is predominant mineral in the bones, and how is that going to affect the weight bearing? How is not going to affect the bone strength? And is the patient going to become at increased risk for fractures? So then the next thing is, thinking of bone demineralization, because change of nutrients, if the patient is not eating well, would that affect on the GI system? If they have low appetite or anorexia, or they're constipated, all that GI functioning with the compromise with the decreased mobility, like I said, constipation, nausea, indigestion, decreased appetite. This all is going to affect the metabolic functioning of the patient. So some of the assessment in the metabolic changes is going to be, the height, the weight. We're going to look at the protein levels, and those are all going to feed into also other elements of risk factors, where like the risk for infection. This is going to be affected in preventing. Like if we don't get enough proteins, that's going to affect our ability to fight infections. So we have to look at assessing the protein level. What is the patient eating? That diet should be high in protein, high in uh, high caloric diet, supplement with vitamin C, vitamin B, also vitamin A if we're thinking of healing. So now, what's the respiratory system have to do? When we're in bed, we're gonna have that decreased lung expansion. And that decrease in lung expansion is going to cause atelectasis. We talked about pooling of secretions. There's going to be decreased surface area for exchange of CO2 and O2 because of that decreased lung expansion. And so most of um, uh, uh, the complications that you're going to see are in that hypostatic pneumonia. And this is what you see with patients with decreased mobility, where the buildup of secretions in the lower lungs that are dependent is going to be the reason why they're going to have infection in there. And so when we assess, we have to do the full respiratory assessment, observe the chest movement, auscultate for pulmonary secretions, check oxygen saturation, breathing pattern, observe for any signs of respiratory difficulties. And then what can you do? You can do so much. You can do the deep breathing, coughing exercises every 2 hours, chest physiotherapy, make sure that the airway is patent, use the incentive spirometer. Definitely, we talked about these and how we are going to use all these preventive measures with post-op patients. Then the cardiovascular system, with decreased mobility, you're gonna see orthostatic hypotension. You're gonna see blood pressure that is changing when the patient changes their position, like with the difference between laying in bed for a long time and then the blood is pooling, and then when you stand up, your blood vessels are not gonna have the opportunity to um, react to that change, and then you see that orthostatic blood pressure. The patients will complain of dizziness, lightheadedness after they stand up. Another one thing that you're looking for with the cardiovascular system is the increased workload. Um, because you're not going to have that venous return coming back, and so that's going to affect because of the dependency of the vein, the veins, yes. And remember, we talk about deep vein thrombosis. This is where the blood is pooling. Then you have more chances for clot formation. And if we have a deep vein thrombosis because of the pooling of blood, then that clot can move and go into the pulmonary vasculature and cause pulmonary emboli. Um, you're gonna see also when they are constipated and they may do that Valsalva maneuver. You can see that vagal nerve stimulus and then bradycardia and the complication of the innervation of the vagus nerve. What do you do as assessment? Yes, your blood pressure. You make sure that you are paying attention to postural changes and the fact that the patient may go into orthostatic hypotension, pulse, edema. Of course, you're looking for deep vein thrombosis symptoms. That's a hot extremity, swollen, pain. And what can you do for those patients? Definitely dangling feet before standing is going to prevent the orthostatic hypotension. Tell the patient to take deep breath rather than using the Valsalva. Exercise, range of motion. You'll see that they'll use SCD, the sequential compression devices. If the patient has a problem with the deep vein thrombosis, you're not going to massage the extremities because then you're encouraging that clot to move, and you're definitely looking for those signs of DVTs. The extremity is going to be warm, red, and then you're going to have positive Homan sign, which is when you press at the popliteal level, you're going to have pain, complaints of pain from that patient. On the musculoskeletal system, you're going to see, because of decreased use, you're going to see decreased muscle mass. And that decreased muscle mass is coming from that muscular atrophy. Then you're going to see also decreased muscle endurance, decreased stability when they stand. And the most difficult musculoskeletal changes you're going to see is that joint contractures, and then you'll go into osteoporosis and disused from that. So how do you assess that? See how much range of motion can they do in the extremity, and eventually that gets us into the talk of, okay, can we do something about this? Yes, you can encourage range of motion. If the patient can do it on their own, that's the active one. If that not, then you have to do passive range of motion because you need to prevent those contractures, the foot drop, and you individualize the plan of care based on how much that patient can take. And of course, remember, remember we talked about progressive exercise program for these patients. We want them to get up and moving as much as possible, but we want to work with their abilities. On the genitourinary system, we know we talked about urinary stasis. You're going to see also renal calculi, so stones in the kidneys. And we talked about UTI and how immobility and lying on bed is is difficult because we can't empty our bladder with gravity like if we're on a bedpan, same like what we're doing in the bathroom on the commode. Is what do you do as an assessment? You need to check for intake output, make sure that the patient is doing proper perineal care from front to back, look for those signs and symptoms of a UTI, and also your interventions are preventing those UTIs. So fluids, you need to get those patients drinking more fluid and documenting the intake output. And if we're suspecting any stones, you'll see that you're going to be using that strain the urine to detect any stones. The patient's going to be in severe pain. That's a definite thing you're going to pick on. The GI system is another we have a system we have to look at, and so when we look at the GI system, we're looking at the biggest problem with immobility is the fact that the patient can get constipated. But constipation is not our main worry. We're worried about the severe type of constipation where the patient is going to have fecal impaction. Patient post-op, if they don't get up and get walking and they're taking pain pills, which are going to contribute to the sluggishness in the GI tract. So you'll have those patients with constipation. Again, like I said, our problem is with that fecal impaction. So assess, listen for the bowel sounds, and you're looking for absence or decreased bowel sounds as signs of constipation or problems with the GI tract. Ask the patient, have they pooped? That's assessing for the bowel movements. And then when they poop, you look at the stool, what type of stool they're getting out, record the encourage fluid. If needed, give them those stool softeners. And with fecal impaction, you're going to see that they need to do digital removal of the fecal impaction. You're looking also at your elderly patients who's having surgical procedures and how it affects the GI tract. So, with their normal aging, you're looking at, okay, I'm gonna increase the fluid, I'm gonna increase the fiber diet, I may give them stool softeners or laxative prophylactically. The skin here is of utmost importance when we have a patient with decreased mobility because they're going to get pressure injury. They're at risk for that shearing friction of the skin because they're immobile and we're positioning them. So the skin breakdown, impaired tissue integrity, impaired skin integrity is going to be a key with these patients, and also their increased risk for infections. Um, so when we um, assessing this patient, we need to be looking and inspecting the skin, and we need to be looking for any signs of bed sores. And we'll talk about this with skin integrity in details because we have a whole module around this. Um, about in maybe a couple of weeks. And then we will assess those pressure injuries at what level they are at. We'll talk about this in more detail. It's just you have to know the basics of integumentary changes and what you're doing, keeping the skin clean, keep moving the patient so that they're not sitting in a stagnant position. They're not sitting for a long time on a bony prominence. Definitely, you need to know those bony prominences and their positions. So your interventions are based on identifying those at risk, daily or every shift integumentary skin assessment, changing position at least every 2 hours, putting emollient or barriers, skin barriers for those who are incontinence of urine, massage so you can stimulate circulation. Use those pressure support devices. You have boots, you have SCDs, use those to help prevent further complications. Lastly, is that psychosocial effect, decreased immobility, decreased mobility. I mean, you're trapped in a bed, you're in a hospital bed on your own. You have to pay attention to those psychosocial impacts. So look at the behavioral changes. Is the patient having behavioral changes? They may get confused. Are we maintaining their sleep-wake cycle? Are we enabling them to be more independent? So get them to be more independent, get them doing their own range of motion, look for signs and symptoms for depression. So what you can do, encourage family interaction, socialization, get them to have those neuro stimuli, help them comb their hair, keep them looking fresh, feeling fresh, looking their smell. They're not kept in their uh, pee or poop, and do not interrupt their sleep. If you can maintain that wake sleep cycle. Um, Also, you need to work on collaborative elements where we talked about frequent turning, positioning, skin assessment, range of motion, deep breathing, elimination, nutrition. All these are gonna be things we do to prevent those systemic effects, long-lasting systemic effects from immobility.